phospholipids. So phosphatidylcholine is something that we can use nutritionally to help with the cell membrane. And phosphatidylcholine also has a way, because it's lipophilic, it sort of can grab onto fat-soluble compounds, toxins, etc. And so we're using this nutrient, phosphatidylcholine, to basically rebuild the cell membranes, but also to pull the toxins off. And so in that case that I presented, that 15-year-old boy, we did actually an oral protocol. We changed his diet, we did a lot of things, and then we started supplementing with a variety of nutrients, including phosphatidylcholine. And what we're waiting for is a repeat IGL epigenetic test, because what we would want to see after treatment like this, where you're basically just binding all the bad stuff, you're pulling the lindane off the DNA and you're rebuilding the cell membrane, the repeat test should show the lindane is gone. And that's what we're waiting for. So that would be exciting. I wish I had that report to give to you today, but it can be done, this protocol, what we call membrane exchange, can be done in a variety of different ways, and there are certain very specific protocols. I have my own way of doing it, and often oral is fine, and sometimes we do use an IV formulation as well, especially if we want to detox the patient a little bit faster. So I hope that's cleared up that. The other nutrients will be things like butyrate, which is a short-chain fatty acid, and going back to the microbiome, again, I think is really, really important. A lot of the, what we call, I would say, methylated nutrients like B vitamins, very, very important. And things like probiotics, and the diet piece is critical. I mean, we've been talking a lot about diet, but in these patients, a low-carbohydrate diet that is really, I would call it modified ketogenic, a higher fat but good fats, low carbohydrates, moderate protein works well for these patients. So that's a general approach.
Okay, and that was for lindane. One of those toxins is it relevant for?
I'm sorry?
That was, you spoke about in the case study, it was for lindane. What other toxins is it relevant for this exchange? Is it EDCs? Is it heavy metals?
Yeah, actually all the above, because we've already seen on that IGL test things like aluminum, sitting as DNA adducts, right? And whether that comes from vaccines or whether that comes from other environmental ways of getting aluminum in, deodorants and pots and pans and all that, who knows? But we use this exchange for aluminum, mercury, lead, so all the heavy metals. We've also seen a variety of what we would call, I'll call them heavy metals, but not the traditional kind. It's not uncommon for me to see things like inorganic gold and some other metals and that are sticking there for who knows why, and we'll use that in membrane exchange for that too. Pesticides we covered, and organopesticides we've seen. I'm trying to think if there's anything else, but generally I'm going to use it for anything that I see as a DNA adduct.
Okay, great.
Uranium, yes, good point, thank you.
Dr. Gottfried, now you gave out a protocol of starting with lifestyle, moving on to, say, botanicals, and then if that fails, moving on to vitality.
Are you awake?
That's moving to the athlete. Bioidentical hormones, at what point do you bring those in? When do you determine that the treatment's not working? Is it a time frame? Is it biomarkers? When do you bring those in?
Yeah, I would say the answer to that question relates to the science of hormone balance. So we know that it takes typically 6 weeks to reach homeostasis with any change that you make to hormones. So what I do with lifestyle modification is to institute it, give my patients a lot of support around change management, because I think that's so important so that these changes stick. And we do it for 6 weeks, and then we retest. If that doesn't work, we move on to botanicals. In some patients, I'll combine those two things, especially if I think they're going to see results pretty rapidly, and their food, for instance, is already quite tuned. And then, in general, I would say 6 weeks before I move on to something like bioidentical hormone balancing, I was trained to do in medical school, and my training, which is to, just start, for instance, a woman with hot flashes and night sweats on hormone therapy, and then, see later in 3 months. So I think it's much better to have this foundation of lifestyle medicine first, and then often the doses can be much lower and often a shorter duration.
That makes sense, great. Dr. Peake, fantastic presentation. It was fascinating about the early childhood trauma. So the really great question that came through about perhaps childhood trauma is being suffered by children in various countries. There are countries there isn't obesity, and it's been happening probably through the ages. Why now with the obesity epidemic? Is there something else with the childhood trauma? Is it plus the hyperpalatable foods? What's the link there?
It's a really, really good question. When Felitti and his colleagues, and then followed up by others, first examined this whole issue of childhood trauma per se, what they found was that there was so little discussion or exposure or an ability to be able to draw it out of the children, teens and preteens over the years. And this was something that was basically integrated into a lack of a family system that was supportive. The grand majority of these individuals felt abandoned. Childhood trauma is certainly nothing new globally, culturally, for years and years. What we're now seeing, though, is childhood trauma which is occurring in an obesogenic environment. So, as I said to you before, one of the things that kids reach for to anesthetize and to numb the pain is something, one of the only things they can actually feel reward with at a very primal level, and that's food. And it's usually the hyperpalatable foods, because that's the level of pain. So you have abuse, trauma, however you want to define it, occurring within an environment where food is ubiquitous, and the grand majority of it is the hyperpalatables that these children and teens are running for. So that's the difference. You have trauma everywhere, but you don't necessarily have an obesogenic environment. The combination of both is pretty lethal.
It's fascinating. Unfortunately, to keep moving on. So Dr. Stone, thyroid autoimmunity. When treating a patient, what are your goals? What's the main focus? Lowering the autoantibodies or monitoring the TSH, T3, T4? What's your sort of hierarchy you're trying to achieve there, or both?
I would still on. So hopefully from that presentation, the goals are decrease symptoms, remove the root cause of the issue, and then, when I was trained, it was all about TSH. Now it's really more about the ratios and trying to figure out, and in those slides that show the ideal ratio or the optimal ratio, that's really what we're going for. And so it seems a little nondescript, but at the same time, it's very specific, meaning that you really have to take very seriously the signs and symptoms and recognize if you're not getting adequate sign and symptom relief, then you have to ask what is blocking the different receptors, what is driving the autoimmunity, and what is continuing to be the block for normalization of our markers.
And do you have a sort of time frame similar to Dr. Gottfried, like when you start searching for the drivers?
You should be getting movement within a couple of months. Symptom relief should be quicker than 3 months. You can check the labs at 3 months.
Okay.
And so then, but we're beginning to mobilize, looking, we're pretty quick to start looking at whether they're food immune drivers, right, or if they're heavy metal issues. I mean, some of that as we start checking right out of the gate.
Okay, beautiful. Dr. Dempsey, the IGL test is fascinating. And that's in Germany. I've downloaded a few PDFs. My Deutsch isn't so great. So can you describe what this test is? What is it looking at? And you mentioned it as the future of medicine. How are you using it at the moment?
So the IGL test, there are actually, I think, a couple of labs in the world that do a test similar to this. They're small labs, unfortunately, and they don't have the capability of really getting to the level that I think they need to be to help more patients. But, you know, it's an epigenetic test. So it's looking at cell structure. So it's looking at the cell membrane, and it's looking at the mitochondria and the components of the mitochondria, including the mitochondrial membrane. And it's looking at the DNA and looking for DNA adducts, which is the epigenetic effect. It does measure mitochondrial function. It does measure ATP production. There are a number of other things you can do, and there are a number of different panels that you can do. I tend to, cast a wide net in terms of some of the workup that I do, and so I typically get the Rolls Royce of tests if the patient can afford it. It's not cheap, but then we can have all those pieces of information, understand the functioning of the cell, understand energy production and structure, and then the epigenetics, and then I can treat all those different pieces. What it's really providing on some level is a root cause. It's not going to give me all the information. So for instance, I treat a lot of patients with tick-borne diseases, like Lyme disease. This test is not going to see the Lyme bacteria sitting on a DNA. I'm disappointed. I sort of hope that it would show something like that, because then we can prove the presence of tick-borne diseases and the cause of a lot of the chronic diseases we see. So my point is that it's one piece of the puzzle of what's going on with the patient, and often there's more, and you have to use lots of different types of tests to sort of put the picture together. But understanding the toxicity and their dysfunction of the cell, right? I already can start moving that through nutrition, through supplementation, and from eliminating the triggers and eliminating the insult on the cell, and we're moving the patient to better health. Is it enough? I always question this myself. Is it enough? Is it going to change everything? And in some cases it does. Like all patients, right? There are some that are going to respond remarkably well, and in others there's still going to be another root cause. And as even Michael said, you have to always look at all these different possibilities and causes. And this is one. Does that answer the question?
Just quickly, when do you apply it? Is it in all patients? Is it a cost thing, or is it a condition thing?
Well, I think there are three problems. One is the lab's capability. So they limit the number of tests that we can send in per month, unfortunately. So you do have to case select. Number two is the cost. So in US dollars, it might cost, again, there will be creme de la creme of tests. It could be, $1,200 or $1,400. It's, again, not cheap. And I guess the third is, the interest of the patient and how I feel like the patient and the family will respond to the information. Because sometimes it is a little scary. Like I knew with this particular patient that, this was a family that was willing to work on their lifestyle and their food, and I knew that we can use that information productively. In some patients, if I do a test like that, then I'm going to scare them. They're going to close off, they're going to question, they're going to say, why doesn't any other doctor do this test? And so it must not be that valid. So again, I think you have to case select. Eventually, if this lab or other labs can do this on a larger level and a cheaper level, I think it probably has a role in lots of patients.
Dr. Gottfried, you mentioned in your hierarchy the first step was to unlock cortisol. So can you just explain that e-testing? What do you mean by unlock cortisol?
Oh, that's such a good question. I feel like this is the project of a lifetime. Unlocking cortisol. I don't know what your experience is in your clinic, but it's a challenge. I think the older I get, the more challenging I find it. So what I mean by unlocking cortisol is to give patients a list of what helps to reset the HPA-TG, focused on the production of cortisol. So what I encourage my patients to do, the way that I say it to them in the office is, I want you to make an a la carte menu of all the things that sound interesting to you so that we can unlock your cortisol. And so for some people, that's going to be going to yoga 3 to 5 times a week. Yoga happens to be one of the ways that I love to modulate my cortisol response. For other people, they want a quicker fix. And, you know, just as in traditional medicine, I don't believe that you find the answer to health in the bottom of the pill bottle. And so I think that you have to have these lifestyle factors in place along with things like ashwagandha, rhodiola, other adaptogens. You know, we know that there's randomized trials showing that these adaptogens can change cortisol levels, they can reset the HPA-TG. But I also don't think that you can just pop a pill and carry on with life as usual. So I think you know, the first layer with patients often starts with just looking at the sources of stress and seeing if we can change it. You know, for some women, it's a relationship that's toxic. You know, we heard about that and the effects on cortisol as a marker. For other women, it's caregiving. You know, that's a common source of stress, and that's not my opinion, that's the opinion of the American Psychological Association and their annual survey of stress. So that's a huge source of stress for many women. So I don't really have a short answer. I did have a slide on a protocol for how to address high cortisol. I also have a protocol for low cortisol and also for folks who have high and low within the same day. I mentioned some of the botanicals that I think are really effective. I don't use cortisone in my patients. But I think it's important for women to find what moves the needle for them. I mean, that's true for men too, right? And often, it's almost like lather, rinse, repeat. Like, find what really works for you and keep doing it over and over again. You know, habitualize and find ways to dance with stress in a different way. So for me, meditation is a big part of my practice. You know, that certainly lowers cortisol. Any sort of contemplative practice, anything that helps you develop your witness consciousness, to objectively witness yourself. One other tech-supported strategy that I use, and it's also in my slides, is, I think these are the slides that are coming in your app because they were missing from my presentation. I like to measure heart rate variability. So I'm a huge fan of, you know, checking your hormones. I think is very helpful. I tend to do that, you know, quarterly in my patients who have some sort of active change that we're after. But I really like the daily practice of measuring heart rate variability. And so you probably know about this already. You know, your heart doesn't beat 60 beats per minute, 1 second between each beat. There's quite a bit of variability from one beat to the next. And it's a measure of the balance between your sympathetic nervous system and your parasympathetic nervous system. So I measure my heart rate variability every morning. I use a bracelet called the Wellbe. It sounds almost Australian. And so it tells me, it gives a really good readout for patients. It says, Sarah, you're 60% stressed today. And then I'll do a guided visualization that's within the app, and it'll take my 60% stress level down to 14%. I can live with that. Another thing I use is the Aura Ring. Any fans of the Aura Ring in the room? They have a new model that's coming out right now. It's made in Finland, and it's a ring that measures activity, heart rate variability. It also does sleep tracking, including deep sleep, REM sleep, light sleep, interruptions. So I think wearables can be really helpful with the cortisol unlock.
Great, thank you. Dr. Peake, you spoke about, obviously, the food addiction, and it's a fascinating question that kept coming through is how do we tackle this? Is it just a purely biological thing, or we're trying to hack into the hypothalamus, or is it a sort of a psychosocial thing? How do we tackle this?
Another excellent question. What we've really been looking at it is a psychobiological phenomenon. It involves two things going on at the same time in parallel. It's not an either-or situation. When you begin a cycle of addictive eating, it's like any addictive cycle. It builds on itself over time. The psychological sequelae from that begin to build exactly the same time. So you've got two things going on in parallel. One feeds the other in a vicious cycle. So the way you tackle it is using a lot of the same kind of recovery methodology that you use in all classic addiction, except this is a very tricky situation. Think about it. You don't need heroin to live. You need food to live. So now you have to differentiate. One of the easiest things we learned, and I work with a team of chefs who actually culinary nutritionists who are rare breeds. These are master's level nutrition registered dietitians who also are certified by the Culinary Institute of America as chefs. So they're both. They can work with food and educate. One of the things we've learned is how to switch out. The first thing is just the absolute avoidance of the hyperpalatables. The hyperpalatables are just going to trigger nothing but trouble. And one of the biggest ones is just granulated or processed and refined sugar. And will you have to be this way forever? No, because it turns out there's this huge variability in human beings. Some people, those people who tend to have an addictive genetic past history, in other words, mom, dad, they themselves, they tend to struggle very greatly with this. And so for them, keeping away from the grand majority of the hyperpalatables is extremely important. There are other people who really are able to have sort of a soft exposure to that in recovery at some point, and it really doesn't trouble them. They don't become people who go back to binging all over again. So food is a tricky one here, but you know, as Michael Pollan and I have said time and time again, as you know, Michael Pollan has written so many phenomenal books on this topic, that you want to avoid what I call science fair projects and what he calls food-like products. This is not food, you know, think Twinkies and all of those kinds of products. That's not food, that's just pollution, that's self-pollution, and it always involves the hyperpalatables. So in essence, what you're really doing here is we have had to put together a recovery type program where you switch out the processed foods, what I call the false fixes for healthy fixes. I'd like to get you hooked on, you know, Whole Foods. I would like to have you literally replace one delicious, satisfying whole food for the processed food. And believe it or not, it's easier than you think it is. It's a lot easier if only people would do one thing. Cook. Nobody cooks anymore. Somehow the microwave, the waver, has become like, you know, that's it. You throw it in there and you run. So, but to actually cook and to reestablish a brand new and healthy relationship with food that nourishes, that whole food, is absolutely essential to the recovery process. It's essential, but it's lacking. And so this requires a whole team effort. And it makes it a little bit more complicated or different, certainly unique, than if you were getting off heroin or cocaine or morphine, where you simply do one thing, avoid that completely, and never go back to that.
Right.
Here, food you have to reestablish.
Excellent. The short answer could have been buy your book and you'll be out there selling in a month. Unfortunately, we haven't got any time left for any other questions, but what we will do, we'll get back to everybody that has submitted a question. The presenters will be around here. How can I guide up the stage?
I have one question. Do you
Okay.
ever use gratitude journals in your work to help people shift
accessible by everyone. And there was a rigorous study done by, at the University of Pennsylvania, the guy that does positive psychology. Oh, do you remember? I can't think of his name. But he did this really interesting experiment where he looked at people who spent 5 minutes before they went to bed and wrote down what went well. And they did it for a short period of time. I can't remember exactly what they did in the study, maybe just a few weeks. And they found that this dramatically increased happiness. And it was sustained. So 6 months later, they were still happier. So it's a very important addition.
Barbara Friedrichsen has done a lot of work in this field because she's a positive psychologist as well. And she's actually looked at epigenetic changes, specifically in the inflammatory loci of people who have become more joyful, more grateful. But here's the wild part, more connected to other people. She found that to be a profound way to be able to decrease total body inflammation as evidenced through the epigenetic methylation that she was following in the inflammatory loci. So I think that this point is extremely well taken, and all of this is free. It's all free.
Very good. I think we're all very grateful for you for being up here this evening. So speaking of connections, we're going to network now. So I'm going to throw it back to Danny to wrap up the day.
Thank you, Nathan. And just to reiterate Nathan's sentiments, I'll be writing my gratitude journal tonight, thanking you all for contributing to an awesome day one at Congress. Thank you so much. Flav